Okay, well, I hope everyone had a great lunch and refreshed and ready to do our afternoon session. We have a terrific lineup here, and I'm anxious to get going, but I'm going to have Nicole Tuhig give us a few ground rules for how we're going to do the session, which are familiar to you now, but we're gonna for those who may have just come on, please.
Yep. Just in case we have any new participants this afternoon, our chat is open, so please feel free to introduce yourselves to each other so you can all see who's participating. We ask that you put your questions for our speakers in the Q&A box as opposed to the chat box. We will share these questions at the end of our presentations, and Steve will moderate the Q&A portion of this session at that point in time. We are recording these sessions. They will be posted to our website and our YouTube channel by the end of next week. So keep an eye out for those, and we will let you know by email when those are up. And you can follow along with our VCBH 2020 hashtag on Twitter. So that's all for me.
Okay, great. So as you can see in the program, our first speaker is a member of the Vermont Center on Behavior and Health family, Hypatia, known as among her friends and colleagues as Tia Bolivar. And she is now an instructor in the Department of Psychology at the University of Illinois in Springfield. Tia completed her PhD at the University of Florida, where she worked on various projects targeting cigarette use, including randomized clinical trials using contingency management to reduce smoking. She completed a postdoctoral fellowship at the VCBH under the mentorship of Diane Galima, where she received training on nicotine delivery systems, low nicotine content cigarettes, clinical trials research and project management, behavioral interventions to promote healthy behavior. Her primary interests are on relapse and maladaptive health behaviors. She continues to collaborate with the VCBH as she teaches and trains future generations of psychology researchers at UIS. Tia, please take it away.
Thanks, Steve. All right. So I hope you can see my screen.
We can.
Oh, great, thanks. All right, hello. Thank you so much for the introduction, Steve. Today I'll be discussing a meta-analysis on the use of contingency management with people receiving medication for opioid use disorder. I have no disclosures. I would like to thank my many co-authors and mentors for their continued assistance on this project, and some authors are receiving financial support. As is made evident by the purpose of this conference, the United States is facing a public health crisis in the opioid epidemic. Over 10 million people above the age of 12 years old reported past year opioid misuse in 2018, with many reporting misuse of prescription opioids and also the use of heroin. Dr. Matthew Ellis highlights the problem of polysubstance use in people who abuse opioids. In particular, it is troubling to see the surge of psychomotor stimulant abuse in people seeking medication-assisted treatment for opioid abuse. The RADARS system collects data from 71 participating programs that offer such treatments. Their data show that between 2012 and 2018, reported rates of past month methamphetamine use climbed from about 8% to 21% of respondents. Other risky behaviors that were associated with past month methamphetamine use included past month injection of opioids and past month cocaine use. Thus, one significant and critical concern is whether this surge of psychomotor stimulant abuse will undermine the considerable progress that has been made in treatments combating the opioid epidemic. Medications for opioid use disorder or mood include methadone and buprenorphine, and they have been key in treatment for people who are abusing opioids. However, to date, there remain no parallel pharmacological treatments for stimulant abuse. Therefore, we must use evidence-based psychosocial treatments to help these patients. Among these evidence-based treatments, contingency management appears to be the most effective. A recent meta-analysis by DeCrescenzo and colleagues evaluated 50 randomized control trials, and they found that monetary-based contingency management was the most effective intervention for increasing stimulant abstinence at the end of treatment and at follow-up. Contingency management is a behavioral intervention that involves the delivery of incentives contingent upon verifiable behavior change. Seminal work in contingency management was conducted by Steve Higgins and his colleagues and showed that CM was effective in increasing cocaine abstinence. CM is effective with drug abstinence or drug reduction as the behavioral target, but it has also been shown to work with non-drug behavioral targets, including medication adherence and therapy attendance. Previous work that has reviewed and synthesized the literature on contingency management has either not focused its effects on people receiving medications for opioid use disorder as the target population, or the data are outdated or more limited in scope. Again, many clinicians and policymakers are facing a public health crisis in the opioid epidemic, and this now includes a concern with the surging concomitant use of psychomotor stimulants. Thus, we sought to provide a comprehensive and updated review and meta-analysis on the effects of contingency management with people receiving medication-assisted treatment for opioid use disorder. Our review does include several drug and non-drug targets, but today I will only be reviewing the results for studies evaluating the effects of CM on reducing psychomotor stimulant use and polysubstance use. We conducted our search using PubMed, Web of Science, and the Cochrane Controlled Register of Trials databases. We searched all dates prior to May 6, 2020. Our search terms included terms that were related to contingency management and financial incentives or to substance use disorders. We also examined reference lists and previous reviews of CM to make sure we weren't missing anything. Our inclusion criteria were based on previous reviews and included the following. The article had to appear in a peer-reviewed journal. It had to report results from an original study. It had to test a monetary-based contingency management intervention. It had to use a prospective between or within participant experimental design. It had to include a no incentive comparison condition. It had to use a research design allowing attribution of treatment effects to contingency management. It had to report findings where all participants were receiving medication for opioid use disorder, or there was a sub-analysis in which data were exclusively from participants who were receiving mood. And then finally, the results had to report findings from at least 10 participants. At least 2 authors reviewed all articles at the title abstract level for full text review, and at least 2 authors evaluated full text articles for final inclusion. Disagreements were resolved by consensus. The data that we extracted included the behaviors that were targeted by the contingency management intervention, the medication that was used in the study, the duration of contingency management in weeks, the max possible earnings in the contingency management intervention, and end of treatment and follow-up outcomes. We prioritized the longest duration of abstinence whenever this information was provided, but other outcomes could include % of negative samples and % of participants abstinent. The database results identified 2,242 articles. After we removed duplicates, we had 1,435 articles to screen at the title and abstract level. we included 8 additional articles from reference sections of relevant papers and reviews. Of these articles reviewed at the title and abstract level, we included and read the full text of 215 articles. Ultimately, we included 75 articles in the review. 72 of these articles reported during treatment or during treatment and follow-up results, whereas 3 articles reported only follow-up data from articles that were included in the previous 72. So some articles only had follow-up data. Cohen's d was the measure of effect size that we've used. Effect sizes were computed based on the reported test statistics or the descriptive statistics if those were needed. For studies with effect sizes that involved multiple comparisons, so studies with multiple groups, the effect sizes were averaged across comparisons in order to generate an overall effect size for the study. And random effects meta-analysis models were used. First, I'll discuss the studies that targeted abstinence from psychomotor stimulants. We included 22 such studies. 90% of these studies showed that CM resulted in significant increases in abstinence at the end of treatment. 90%. Methadone was the medication used in all but one study in this category. The mean duration of contingency management was about 17 weeks, and the mean maximum daily earnings was about $17. This slide shows data from the 24 studies that we included that target polysubstance abuse. In this category, 58% of the studies showed significant increases in abstinence at the end of treatment. Among these studies, the type of medication use varied much more widely, although methadone was the most commonly used. The mean duration of CM among these studies was 15 weeks, and the mean maximum daily earnings was about $18, so similar to the mean maximum earnings for studies targeting psychomotor stimulant use. Notably, psychomotor stimulants were among the many substances that were targeted in these studies. So psychomotor stimulants were included in all studies as a behavioral target. So this table and forest plot shows the results of the meta-analysis for studies targeting psychomotor stimulant abstinence. And I'll pause for a second here. We were able to calculate the effect size for 19 of the 22 studies that we included for review in this category. As you can see, CM produces moderate to strong positive effects across most of these studies. And the overall effect size, represented by the diamond here at the bottom, was 0.68. and was statistically significant. This table and forest plot shows the results of the meta-analysis for studies targeting polysubstance use. We were able to calculate effect sizes for 19 of the 24 studies that we included in this review. In this category of studies, the effect size results were more varied. However, overall, the Cohen's d, again indicated by this diamond here at the bottom, was 0.38 and was statistically significant. Excuse me. So in conclusion, we examined the past several decades of literature on the use of contingency management with people receiving medications for opioid use disorder. We have found compelling evidence that CM is a highly reliable intervention for reducing psychomotor stimulant use and polysubstance use in this population. In particular, we observed moderate to large effect sizes for the psychomotor stimulant abuse category. The effect size does appear to diminish somewhat when targeting multiple substances, but still shows that CM is efficacious. It's interesting to note that among the studies targeting polysubstance use, the number of substances that were included in these studies ranged from 2 targets to up to 7 targets. And this may help us to understand why the effect size varied more across these studies. In the context of an urgent and very critical need for highly effective psychosocial treatments for combating polysubstance use in people receiving medications for opioid use disorder, CM is really poised to make a serious and important contribution. But of course, there are still some challenges that remain. First is the ever-present concern with long-term maintenance of treatment effects. The work of Dr. Kenneth Silverman and his colleagues suggests that the long-term use of contingency management may be needed in some situations. But it is important to note as well that long-term maintenance of treatment effects is not a problem that is unique to contingency management. Many treatments face this relapse problem as an issue. Additionally, getting contingency management into the community settings where it is sorely needed is a big challenge. We are hopeful, however, that much like the dissemination of medication for the treatment of opioid use disorder, that continued demonstrations of the effectiveness of contingency management, including the data that I've shared with you today, will lead it to becoming a treatment that funding sources, especially Medicaid, including Medicaid, will cover. So that's what I have for you today. Thank you so much for your attention and your time.
Okay, thank you very much, Tia, for that very clear and well-delivered presentation. So if you have questions for Tia, please use the Q&A button, and then we are going to field those questions at the end of the panel presentations. I must say, though, that one thing across my mind is when we're dealing with the opioid, with MOUD, and we're worried that the incentives don't work after they're discontinued, that is the very case for the medication itself. So there's some irony as that being a reason for not using CM with that population. But anyhow, okay. So we're now going to move to our next presenter, our next presentation. The presenter is Michele Lofwall. Dr. Lofwall is a professor of behavioral science and psychiatry at the University of Kentucky College of Medicine in the Center on Drug and Alcohol Research. She is the Bell Alcohol and Addictions Chair and also medical director of the First Bridge Clinic, which provides comprehensive outpatient opioid addiction treatment to patients discharging from emergency rooms and inpatient medical surgical services. Her research has been funded by the NIH and industry and has recently focused on evaluation of long-acting buprenorphine formulations, including CAM2038, Brezati, and Probufene. That's one I'm not familiar with, but that's what Michele does, novel, cutting-edge research, and so that's not surprising. And that's designed for the treatment of opioid use disorder, of course. She is an expert panel member on SAMHSA's treatment improvement protocol, tip 63 for medication treatment for OUD, a past board member of the American Society for Addiction Medicine, and president of the Kentucky chapter of that same organization. She's been an invited speaker to the National Academy of Medicine and recipient of several medical student teaching and mentorship awards. Michele, thanks for being here today, and please take it from here.
Great, thank you for having me. I appreciate being invited to this conference, and so I wish I was there with you all, but maybe next year, right? So can you see my screen? Let me just get it in.
We can see it, Michele.
Okay,
Very clear.
great. And I feel like you just gave like a new like commentary title, Dr. Higgins, about, you know, how CM goes away. Yeah, like doesn't medication effects too? I love that comment. Like that really resonated with me. All right, so we're going to talk about long-acting buprenorphine preparations, or I should say formulations, and really trying to put our thinking caps on about the implications for reducing rural disparities. And let me see, get my slides to advance. Okay, I have one disclosure. I was a consultant in 2019, a little over a year ago, for Camrose. And I'm going to talk about these approved, FDA approved, long-acting buprenorphine medications, really with like an eye towards how can they help us move forwards to improve access and retention for patients that have opiate use disorder. I'm talking about these 3 different products, implant, and then 2 injectables. And then I'm going to talk about 4 ongoing large multi-site trials in the United States using them. And we'll then have some conclusions. So when I look forwards, I try and think about who may benefit, and I think about patients who are having difficult transitions. So I work with colleagues who work in the hospital, and I work outpatient, and we know that we have a lot of patients who are in the hospital who have an opioid use disorder, and it's really hard to not only initiate treatment, but one of the barriers to initiating treatment in the hospital is finding a place for them to go when they're discharged. And a lot of times it's just that the discharging hospital doctor doesn't want to write a prescription for buprenorphine for more than like a day or 2. In emergency rooms, similarly, and of course, jails. So this is a study, JAMA 2015 by Gail D'Onofrio, of sublingual buprenorphine naloxone, initiating that in the emergency room. And they found a 2-fold increase in attending the first outpatient appointment if the person started sublingual buprenorphine in the ER compared to if they were just given a referral. And so that's great. This is a huge result, right? 2-fold more likely, awesome. But many providers are still very hesitant to prescribe out of the ER because they have concerns and about diversion and misuse of sublingual buprenorphine. But what if they could give a shot? So there's no prescription that goes with them. Sometimes, you know, they can't get them into a local provider soon enough, so the ER doc doesn't want to write, you know, a prescription for more than a couple of days. But what if the shot lasted for a week or a month? What about pregnant women and newborns? Is the idea that you have a long-acting so that you don't have a daily peak and trough, does that have any potential benefit for mom and for baby? Do we see any different effects like for neonatal opiate withdrawal? Patients who are at risk for non-adherence and misuse. So we know, you know, patients who've had opiate use disorder or any addiction over time, you know, like they misuse substances. Why do we think that's necessarily going to be any different that just overnight they're not going to be tempted to misuse medication that we prescribe to them if it has abuse liability? And we know that, you know, we try to control for that, and we try to initiate some supervised dosing, or we try to change a different treatment setting or change medications and go to like an opioid treatment program. But still, that sometimes puts a bad flavor in providers' mouths or payers' mouths, where they sometimes start then stigmatizing the treatment. And what about people who are addicted to injection? We know that, you know, those behaviors around injection, you know, there's all the preparatory and consumatory behaviors. It's not just the drug itself that's being injected that people can become addicted to. What if the medication, you didn't have to actually have the person take it and have it be in a formulation that was where they would be able to snort it or to inject it themselves? And patients might have a preference, right? Like, don't you always, if you're a patient, don't you want a preference, right? About what are your options? Wouldn't it be nice if you were given an option where you didn't have to remember to take something every day or every other day or multiple times a day? Patients sometimes are stigmatized at a pharmacy. They don't want to go to the pharmacy anymore. So the idea that they could just get an injection in their doctor's office and avoid the pharmacy is very attractive, and then not having to have any supervised dosing. is also attractive for patients. So where is the other thing, right? Like, where are these patients when we think about moving forwards? And so Willie Sutton was an infamous bank robber from the 1930s. I'm told he was very well dressed. And the big question that always is like the famous question, why do you rob banks? He was asked by a journalist. And he said, well, duh, like that's where the money is. Okay, so where are our potential patients? Where's our, duh kind of thing? And we know it's criminal justice, right? We've got so many of our potential patients who have opiate use disorder that haven't been diagnosed, haven't been offered treatment with medication that's life-saving. And so this is a huge venue that could be a great potential for long-acting preparation that doesn't require any sublingual transmucosal medication. Emergency rooms, hospitals, we already talked about, also primary care settings. It might be a good, helpful place to have more of this available too. And all of these venues, right? Jails, emergency rooms, urgent cares, primary care, they all exist in rural areas where there's huge disparities in access. So the 3 long-acting buprenorphine products that are all FDA approved and on the market are the implants. These have been around for several years, just really have never taken off. They last for 6 months. They get implanted underneath the skin in the arm, kind of like Implanon, if you're familiar with that, for birth control. Its indication is very narrow though. It's for patients who are already stable. They're almost like your almost perfect patients. And they have to be on a low dose of buprenorphine because the rods don't deliver more really than 8 milligrams of Suboxone equivalents daily. Okay, so they're patients who are clinically stable with opiate use disorder, already doing really well on 8 milligrams or less a day. The mean concentration delivered at steady state's a little less than 1 nanogram per ml. It is a minor surgical procedure. We do it in our office. It takes usually no more than 15 minutes, 20 minutes max. They do have to be removed after 6 months and then they can be replaced. The FDA label has approval for 2 rounds and there's no refrigeration required. Monthly Sublocade is the newest injectable that is on the market in the US. It's also approved in Australia. This is indicated for adults that have moderate to severe opiate use disorder that are tolerating 8 to 24 milligrams a day for at least 7 days before. So you need to have this little bit of a run-in before you get on it. And the typical dosing regimen is 300 milligrams for the first 2 months as a loading dose, and then 100 milligrams thereafter. And you can see the buprenorphine concentrations here are high. This is the highest concentration product that we have on the market. There's no surgical procedure required. It does get shipped directly to whoever's going to be administering it. It's not something that the patient ever gets a prescription for or ever gets their hands on. Same goes for all of these, I should say. Okay, so these are products that are going directly into the patient's never getting a prescription themselves. This has to go in the belly, in the subcutaneous, and it does have to be refrigerated. You take it out for like 15-20 minutes before to get to room temperature. The third product here is a weekly and monthly injectable. This is also approved in the United States, but because of Sublocade having exclusivity for several years, being the first injectable to the market, they have not been able to come to market yet. They are in the market in Europe and in Australia, and they are allowed to come to market, we believe, the end of this year, early 2021. So this could be really available very soon. Indication is opiate use disorder, age 16 and above. Again, with counseling, that framework of comprehensive treatment like the other medications. This can be initiated on day 1 of treatment. There's no requirement for several days of a run-in. Variable concentrations, all greater than 1 nanogram per ml, and no surgical procedure, multiple different areas of the body that you can get it, no refrigeration required. I'm just going to spend time talking about Probuphine. There's not a lot of research going on with Probuphine right now. This is the study that showed that it was just as good as sublingual buprenorphine, and then it was actually superior on a secondary outcome of having abstinence for a total of 6 months. And I just love this study because it has optimism and gives me so much hope. It reminds us all that there are a group of patients who are out there and who are clinically stable and they're on 8 milligrams or less per day. and that we need to remember them, and we need to give them treatment options too, okay? So this study recruited those stable patients on 8 milligrams or less per day, randomized them to sublingual or Probuphine, and look at this, 94% retention over 6 months, amazing, so optimistic, right? So there are case reports coming out with patients who have been on more than 2 rounds of this, such as 3 to 7 rounds. We have some of those patients in our clinic. That's unpublished data, but then there's Dr. Campbell, who does also have a case report that's recently published that's cited there if you're more interested in it. All right, so now I'm going to talk about Sublocade, which that's the brand name, but the name that was used in the studies that are on PubMed to establish efficacy before it came to market is RBP 6000. And the study I wanted to tell you about that's really exciting, that is on clinicaltrials.gov if you'd like to learn more about it. I don't think it's actively recruiting yet, but I think it's in hold because of coronavirus. But this is a 5-site open label, non-inferiority trial funded by NIDA that's recruiting incarcerated adults aged 18 to 65 with moderate to severe opiate use disorder that are willing to be on either medication. So either RBP 6000 or extended release zone. And they will be randomized prior to release and receive 24 weeks of medication treatment. And the primary outcome is the number of injections they get, ranging from 0 to 6 over that 24-week or that 24-week post-release treatment. The next 3 trials I'm going to tell you about are involving CAM 2038, the product that we're hoping comes to market at the end of this year, early 2021. I'm just showing you the different doses that are available here. The orange column shows you the sublingual buprenorphine equivalents, and then the next 2 columns show you what the equivalent dose would be in the weekly formulation of CAM and then in the monthly formulation of CAM. And then I'm showing you here the picture of the body with all the different sites that it can be injected, and then this very small needle with what it comes looking like. And I just want you to note how small the volumes are in mLs. You know, none of the injections are greater than 0.64 mLs. So there's 3 new studies starting here, it all being funded by the NIDA Clinical Trials Network that I just want to tell you about. And I think I want you to get excited and be thinking about what other trials maybe you want to do with this, right? Or if you're using any of these products now because Sublocade's on the market and you're, you know, a clinician or you have access to patients or colleagues, what kind of case control trials could you be doing now with these? That because these are new and we have a lot of safety and efficacy data. We don't have a lot of effectiveness data yet. So the first study by the CTN is involving hospital care for opiate use disorder. And like I mentioned earlier, you know, in the hospital, unfortunately, it's really rare that someone is going to be offered medication for opiate use disorder. There's very few addiction medicine consult services or addiction psychiatry consult services. It's often ignored, even if it's the underlying cause for admission, like having endocarditis due to injection opioid use. These are patients, though, that are more likely to be readmitted to the hospital. And when they're in the hospital, they're frequently there for a long time. So it's a very reachable moment, like in the sense that if you had someone there that was a professional that could talk to them, it's very possible that you can get them onto medication when they're there for sometimes weeks on end. There was a study that was done that shows that, you know, opiate withdrawal plus referral versus, you know, receiving actual and starting medication with a referral, that it's much better to have patients who are started on medication with that referral than just, you know, giving them the referral without maintaining them. I think that's common sense at this point, but they just showed that again in a hospital setting. So this is CTN 0098. You can see all the protocol development team. Dr. Gavin Bart in Minnesota is the lead on this. And it's called, I like the name, Exit Entree, little French kind of. So exiting the hospital, but getting an injection before they leave the hospital, and then entering into the clinic. So they are recruiting from hospitals, and they're going to randomize a little over 150 to either extended release buprenorphine, the CAM 2038, or treatment as usual. And they're going to be looking at outcomes over a month, 90 days and 180 days after discharge. And the primary outcome is treatment engagement, just a little bit over a month following discharge. The next study I'm going to talk about is based in the emergency room department. You remember I told you Dr. Gail Giannoffrio's study earlier using sublingual, and it's really this group who's moving, continuing this line of work, but instead of using the sublingual product compared to just a referral, it's now sublingual product compared to the CAM 2038. And so this study is another CTN study. It's 0099, and it is called ED Innovation, Emergency Department Initiated Buprenorphine Validation Network Trial, a mouthful, but ED Innovation. Here is a picture of all the nodes, and it's both Dr. Giannoffrio and Dr. Filene that are leading this at Yale. And it's comparing the effectiveness of that extended release buprenorphine weekly injection to sublingual in 2,000 patients across approximately 30 different sites in the ER, in the emergency departments. And the primary outcome is engagement in formal addiction treatment. Here's a little figure to show you just a simple study design. People have to have opiate use disorder. They also, if they do, they're given overdose education in naloxone, and then they're randomized 1,000 to XR bupe, the extended release bupe, or the sublingual bupe, another 1,000. Okay. Inclusion criteria in this study: 18 or older, in the ED, DSM-5 OUD diagnosis, moderate to severe, COWS score greater than or equal to 8, having a urine test that's positive for opioids, ability to speak English and do informed consent. Next study, we're going. Pregnant women with opiate use disorder, CTN 0080. And this study is recruiting and enrolling and randomizing. So really excited. This one's actually going and started during coronavirus and is going strong. So we know the US opioid epidemic is associated with a significant increase in the prevalence of pregnant women with opiate use disorder and infants with neonatal opioid withdrawal syndrome, otherwise known as NOWS. And we know that's associated with adverse health effects for the infant and with costly hospitalizations. We know that methadone and buprenorphine maintenance treatment are recommended for pregnant women with opiate use disorder. And so this question in this study was, it's a pragmatic outpatient randomized trial comparing extended release and daily buprenorphine formulations. Here's our team. Dr. Teresa Winhusen is the lead investigator. I'm fortunate to be getting to work with her on this study as well, as long as a host of other sites across the country. You can see here, it's a 2-arm open label non-inferiority outpatient pragmatic randomized trial, 12 sites, 150 pregnant women randomized per arm, comparing CAM 2038 to sublingual buprenorphine. The randomization is 1-to-1. We're stratifying by site, estimated gestational age of 6 to 18 weeks versus 19 to 30 weeks, and also taking buprenorphine sublingual at randomization. We're looking at providing buprenorphine for 12 months postpartum, and there's 2 optional studies: a conceptual model assessment where there's going to be some blood draws to try and get some concentrations of bupe and metabolites in mom while she's pregnant, and cord blood at time of delivery. And then also there's evaluation of the neonates and infants through 2 years of age to look at infant neurodevelopment. This is the study schema. We're screening. You can see the randomization while pregnant, the 150 in each arm. The key outcomes: illicit opioid use in mom is the primary maternal outcome. And then we're also looking at the now severity as a secondary outcome. And postpartum, we're looking at maternal illicit opioid use as a key secondary outcome as well. We've got medication check visits weekly, research visits a little less frequently to try and keep this pragmatic. Talked a little bit about these outcomes. There's a multitude of others as well that are planned. And then there's multiple safety as well. Health economics and sub-studies are also part of this. We're looking at incremental cost effectiveness ratios of effectiveness calculated over the 2 study periods, one being during pregnancy through delivery, and then the second being over the course of the entire study. And then the conceptual model study I mentioned is also another interesting study looking at maternal peak and trough buprenorphine metabolites, also looking at fetal heart rate variability, and then that infant neurodevelopment outcome study following the infants through 24 months of age. So in conclusion, I hope this has whetted your appetite. Maybe you'll have some interesting questions you want to think about, or this has got some questions thinking about your own research, access to patients that might be on some of these meds already. I really think that these long-acting medications for opiate use disorder hold a lot of promise for improving treatment entry, trying to get people along that whole opioid use disorder continuum of care, from identifying to helping them gain access and stay retained and go into remission and have a really successful recovery. And that these should be accessible and utilized in rural areas. And I'm really excited to see the results that are going to be coming out, over the next several years about these studies, and that are really trying to do real world clinical implementation in these venues that have our patients. And I'll stop.
All right, well, thank you very much, Michele. That was a wonderful presentation, and it had the effect on me that you were hoping. I'm encouraged. I'm optimistic. I've always thought these extended duration formulations are the way to go. I mean, I think it's a no-brainer in terms of seeing that, although it's developing the formulations and testing them that takes all the time. But the ones you share with us just sound wonderful. So I'm very excited.
It's exciting.
Yeah. I'm hoping that you have some questions for Michele and that you'll put them into the Q&A line, and we will. It looks like we're really saving time, and no one has even approached the maximum yet, so we'll have plenty of time for Q&A. And so be thinking about what items are on your mind and what you want to ask these wonderful investigators. So, okay, we now move to Elizabeth Saunders, a name I was known for quite a while, but have not had the opportunity to connect with a face before this afternoon. So I'm really happy about that. So Dr. Saunders is a senior research scientist at the Center for Technology and Behavioral Health at the Geisel School of Medicine, which is Dartmouth, and it's just right down the highway from us in Vermont. Doctors and many of our colleagues and former trainees run the center. Dr. Saunders earned her PhD from the Dartmouth Institute for Health Policy and Clinical Practice. Her mixed methods dissertation research examined preferences for medication for opioid use disorder using web-based sampling strategies. Dr. Saunders' primary research interest focuses on the evaluation of treatments for opioid use disorder and the implementation of these treatments using both qualitative and quantitative methods. As part of CTBH and the Northeast node of NIDA, Clinical Trials Network, she is currently involved with several studies, including a randomized controlled trial of long-acting MOUD for people involved in the justice system. I'm not sure if that's one of the trials that Michele just shared, but very well may be. And an evaluation of the implementation of electronic health record integrated screening in primary care clinics. Dr. Saunders is also interested in improving outcomes for women with substance use disorders and is engaged in research comparing the effectiveness of integrated versus non-integrated treatment for pregnant women with opioid use disorders. So interested, very much aligned with our prior presenter. So Elizabeth, please take it away.
Thank you so much for having me. I'm going to share my screen now. Let's see. Can you see my slides?
We can.
You can,
Very
great.
clear.
Thank you so much for having me and for the introduction. Today I'm going to talk a little bit about a study that we conducted in New Hampshire, specifically to examine and better understand the rapid increase in opioid overdose occurring over the last few years. Before I jump in, I have no conflicts of interest or financial relationships to disclose. So you've heard from a number of past presenters that over the past decade, the prevalence of opioid use disorders and the rate of deaths from opioid overdose have risen significantly across the United States. Between 1999 and 2010, rates of opioid overdose death quadrupled nationwide, and by 2016, drug overdose deaths surpassed the number of deaths from motor vehicle accidents in the United States. Approximately 66% of these deaths involved opioids. Data from the Centers for Disease Control and Prevention suggests that this increase may be significantly driven by an increase in synthetic non-methadone opioid overdoses from substances like illicitly manufactured fentanyl. Deaths involving synthetic opioids increased by over 600% since 2009. This illustrates the importance of developing effective interventions to reduce overdose death and gathering knowledge about the experiences and the perspectives of individuals who use synthetic opioids and from those individuals who respond to and treat overdose may be especially important to gain insight on patterns and trends of synthetic opioid use and overdose. This information is really critical to better inform policy level initiatives and to develop evidence-based interventions to reduce overdose death. Although rates of overdose deaths have increased across the United States over the past decade, several areas have been particularly impacted, including the Appalachian region and the state of New Hampshire. In 2016, the state of New Hampshire was classified as one of 8 high-burden states by the Centers for Disease Control and Prevention because of substantial increases, specifically in synthetic opioid deaths like fentanyl. From 1999 to 2016, significant increases in overdose deaths occurred in New Hampshire, and rates surged from around 3 per 100,000 individuals to 36 per 100,000, which was more than 3 times the national rate of overdose. Correspondingly, first responders in New Hampshire experienced a more than 3-fold increase in rates of naloxone administrations in the state, and emergency department personnel experienced a more than 70% increase in emergency department visits related to opioid use or overdose. To better understand the factors contributing to this disproportionately high rate of death in New Hampshire, the National Institute on Drug Abuse funded 2 teams at the National Drug Early Warning System and at Dartmouth College to conduct an initial surveillance study in August of 2016. This study included meetings with state authorities, meetings with New Hampshire policymakers, local treatment providers, and with community groups who worked with people who use substances. The results from this preliminary surveillance study suggested that data directly from people who use opioids and from the emergency personnel who respond to overdose was critical to better understand these changing patterns of opioid use. Therefore, the purpose of the study I'll be describing today was to respond to those recommendations and engage both people who use opioids and emergency personnel to evaluate the factors giving rise to high rates of opioid overdose death in New Hampshire. This study had 3 primary aims. First, to systematically evaluate the factors contributing to opioid-related overdose death in New Hampshire. Then to examine the experiences with overdose among people who use opioids and among emergency personnel, and then to obtain their perspectives on policy-level responses to the opioid crisis in New Hampshire. This mixed methods study recruited in total 76 people who use opioids and 36 emergency personnel. All participants completed a 60 to 90-minute interview, which was either conducted in person or by telephone based on the participant's preference. Each interview included a brief demographic survey. The interviews with people who used opioids then had a brief survey asking about substance use histories and experiences with the treatment system. The interviews with emergency personnel instead included a survey asking about their professional history. All participants then completed a semi-structured interview, and the interview questions during this section were all open-ended and qualitative. We developed the interview guide based on knowledge gaps identified from the initial surveillance study. All of these study materials and methods were approved by the Dartmouth College Committee for the Protection of Human Subjects. We recruited participants through advertisements posted on the New Hampshire Craigslist. We recruited participants also by posting flyers in the community, by running newspaper advertisements, and through word of mouth. Sampling for this study was purposive and focused on recruiting participants from 6 New Hampshire counties in order to provide representation from across the state. Because rates of opioid overdose were highest at the time in Hillsborough and Strafford counties, sampling was stratified to include more participants from these regions. Our final sample was recruited between October 2016 and March 2017 and included 76 people who use opioids and 36 emergency personnel. And this sample specifically included 18 emergency department providers, 6 emergency medical services providers, 6 firefighters, and 6 police officers. We calculated descriptive statistics to examine the demographic, employment, and substance use history survey responses, and we then used a content analytic approach to analyze the qualitative data. All of our interviews were audio recorded and transcribed verbatim. We uploaded these transcripts to Atlas TI for analysis, and we developed separate code lists for the people who use opioid interviews and for the interviews with emergency personnel, based on the contents of the interview guides. The initial code list was piloted on 2 transcripts from our emergency personnel and 5 transcripts from our sample of people who use opioids. The research team then added new codes inductively based on emerging themes within the interview. Once we had piloted the coding process, research team members coded the remaining transcripts. We met weekly during this time to allow discussion of discrepancies with coding and to refine our code list. Once all of the interviews were coded by a minimum of 2 researchers, the subtheme analysis was conducted by a pair of research team members using the constant comparison method. Next, I'm going to jump right into our findings and our results. But first, I just want to give you a snapshot of our participants. Among our sample of people who use opioids, our participants were predominantly in their mid-30s. Half of participants were male, while half were female. The majority of participants were white and were not Hispanic or Latino, consistent with the demographic profile of New Hampshire at large. Most of our participants were either working full-time or were currently unemployed and not seeking employment. We had about 20% of participants who were currently homeless, and the majority of our participants were either residing in a home or apartment they owned or were living with family or friends. All but 1 participant reported lifetime use of non-prescribed opioid pain relievers, while more than 90% of our sample reported currently or previously using heroin. 84% of our sample reported certainty that they had used illicitly manufactured fentanyl. Our sample also engaged in significant amounts of concurrent use of other substances, predominantly tobacco, cannabis, alcohol, stimulants, or sedatives. In our sample, about 90% had received some form of treatment for opioid use during their lifetime. And this most commonly included attending residential treatment programs, 28-day or detoxification programs, outpatient individual or group counseling, medication for opioid use disorder, or attending mutual help groups like Alcoholics Anonymous or Narcotics Anonymous. On average, our sample of emergency personnel was older than our sample of people who use opioids. This sample was predominantly male, and our samples of firefighters and emergency medical services providers were actually entirely male. Again, most of our participants were white and were not Hispanic or Latino. Our sample of emergency personnel had extensive experience responding to overdose, and on average, emergency personnel estimated treating about 156 overdoses throughout their careers. All of the emergency personnel, except the police officers, had administered naloxone to patients. When both stakeholder groups were asked about factors contributing to opioid-related death in New Hampshire, there was unanimous agreement among both stakeholder groups that illicitly manufactured fentanyl was the driving force contributing to a rise in overdose death in New Hampshire. While participants agreed that this was the primary driver of increased overdose rates, participants also highlighted a lack of treatment and a lack of harm reduction resources as amplifying this problem. Both stakeholder groups described several characteristics of fentanyl as contributing to heightened overdose risk. So compared to heroin or compared to non-prescribed opioid pain relievers, participants described fentanyl as being stronger and more potent. They also described fentanyl as being cheaper, as being extremely accessible, and having a faster onset of the high but a shorter duration. Because of this shorter duration of the fentanyl high, participants described needing to use more frequently than they would with a pain reliever or with heroin, increasing the risk for overdose and for the transmission of infectious disease. Additionally, all stakeholders described the challenge of determining a safe dose because of difficulty distinguishing heroin from heroin-laced fentanyl. Though some of the people who used opioid sample felt they could determine when a batch of drugs was mixed with fentanyl because of its color, its taste, and its appearance, others acknowledged that they could not distinguish. And this is an example, kind of an illustrative quote from a participant explaining, "The increase in overdose rates is happening because of the fentanyl that's in the dope. It's just too powerful. You think you're buying heroin, but it's really fentanyl, and that stuff is way stronger." Stakeholders also explained that batches of drugs were extremely inconsistent, leading to high concentration of fentanyl in certain parts of batches. And one of our emergency medical services participants explained that the police department used to test the fingers. They'll test in 5 different spots and get 5 different concentrations. You and I may use and be fine, but our friend may use from the same batch and overdose and die because it's a higher concentration. When asking about experience with overdose, the rates of lifetime overdose were extremely high in our sample and exceeded rates estimated by other surveys of people who use opioids. In our sample of people who use opioids, 69% reported experiencing an opioid overdose during their lifetime. On average, our participants reported experiencing an estimated 3 overdoses. Among those participants who had overdosed, 62% reported having received naloxone, the opioid reversal medication. Participants reported that with the arrival of fentanyl in New Hampshire, they increasingly experienced or increasingly heard stories of overdoses happening after individuals smoked or used opioids intranasally. Participants perceived this to be a change from the past when overdoses were perceived to primarily occur after opioids or other substances were injected. When describing their experience with opioid overdoses, most explained that fentanyl overdoses happened very rapidly, often before they realized what was happening. Participants described passing out, but did not generally describe this experience as being aversive. Conversely, participants discussed feeling horrified and terrified when witnessing family, friends, or other individuals overdose, explaining that it's not so much scary that you overdose, it's more scary to see someone else overdose. Among those participants who had received naloxone, the overdose reversal medication, this experience was unanimously described as being aversive. Participants explained that the naloxone would, wake them up, and immediately they would have withdrawal symptoms onset. Participants explained they would be confused about where they were and unnerved by the presence of emergency personnel. This description aligned closely with the description of providing naloxone from emergency personnel who were often frustrated by the strong negative response of people who used opioids after their overdose was reversed. When we asked about experiences with overdose, the emergency personnel sample first expressed confidence in their professional skills and in their ability and training to effectively reverse overdoses. Despite this confidence, the increased number of opioid overdose calls contributed to an emotional toll and a burden. Responders explained that they sometimes experienced feelings of burnout, feelings of helplessness, heightened concern about their own safety or family or friends' safety, and sometimes experienced intrusive recollections. Some experienced symptoms of compassion fatigue or post-traumatic stress disorder. Most reported that they had not received professional support for this toll, but instead developed coping mechanisms like having informal conversations with colleagues and friends, utilizing humor, or on occasion switching professional roles to minimize their time in the field responding to overdose. Another contributor to feelings of burden were frustrations surrounding barriers to treatment referral after overdose events. While interfacing with people who use opioids during overdoses, most emergency personnel felt there was a window of opportunity to connect people who use opioids with treatment or with harm reduction resources. Numerous barriers were reported to stand in the way of this linkage, including a lack of available treatment services, a lack of staff time and resources, a lack of knowledge about the treatment system for substance use and opioid use disorders, and a lack of funding. This firefighter explained that their experiences responding to opioid overdose, that they perceive that we do it so often and we do it so well. We're extremely good at doing CPR. We're extremely good at managing overdoses. It's almost sadly routine, but it is completely routine. And kind of in opposition to that kind of routine and confidence in response, an emergency medical services provider explained that I responded to a residence where a 13-year-old girl had found both her parents. She walks out to the living room to ask her mother a question and they're both unresponsive. To find two in the same house and the circumstances and how that was found, that's probably going to stick with me for the rest of my life. Both stakeholder groups agreed on the critical importance of increasing access to evidence-based treatment for an opioid use disorder. So for example, this person who used opioids explained, when you know someone who's willing and able and ready and physically standing there in the halls of a treatment program, and you say, come back in 8 weeks, that's crazy. You could be dead tonight. 8 weeks is a long time in the trenches. And we heard over and over again a very similar sentiment from all of our emergency personnel who explained, we just need resources. If I have someone who's willing to seek help, I would move the earth and the moon. Then, oh well, there's no beds available for 3 days and they don't have a primary care doctor who can get medical clearance done. In addition to complete consensus on the importance of increasing access to treatment, our stakeholders also agreed on the importance of providing more prevention programs for youth. Additionally, both groups thought it was incredibly important to encourage prudent prescribing of opioids and reduce the number of opioids prescribed by physicians, coupled with improving patient education about opioids, so patients were sort of more aware of the risks of opioids if they were prescribed an opioid by a physician. In addition, both stakeholder groups were in consensus on the importance of dismantling stigma in order to help people who use opioids come forward and seek help or treatment. Though the stakeholder groups were in consensus about some of the critical policy-related responses, people who use opioid group and the emergency personnel group had more divergent views regarding expanding access to medication for opioid use disorder, expanding access to naloxone for laypersons, and opening syringe services programs. While our sample of people who used opioids were largely in consensus about the importance of syringe service programs, medication for opioid use disorder, and naloxone, views of emergency personnel were more mixed. Some emergency personnel suggested opening syringe service programs was a critical step to reduce the spread of infectious disease. Similarly, some emergency personnel thought increasing naloxone distribution to laypersons would be important to reduce harm and potentially reduce the risk of overdose death. Others viewed these programs as enabling opioid use and had reservations about expanding these programs. Due in part to the diversion of medication to opioid use disorder in communities, some emergency personnel also expressed hesitation or opposition to increasing the availability of medication for opioid use disorder. Conversely, our sample of people who used opioids were largely in agreement about the critical importance of opening syringe service programs in New Hampshire. When this study was conducted, no syringe service programs were open, and participants had difficulty obtaining clean injection equipment. Some in rural regions described traveling hours and hours to access a syringe service program in other states, including Massachusetts and Vermont. Syringe service programs were viewed by our sample to be critical to reduce the risks of using dirty equipment or the risks of sharing needles or other injection equipment. Many people who used opioids engaged in use of non-prescribed medication for opioid use disorder, and this was often explained to be happening because of a lack of access to programs, and particularly a lack of access to programs accepting Medicaid. Many study participants desired prescribed medication for opioid use disorder and strongly advocated for increasing the number of programs and openings, especially for patients on Medicaid. Finally, our sample of people who used opioids felt that access to naloxone was increasing in the state. Despite this, they thought that increasing distribution of low-cost or free naloxone that didn't require insurance was really important, and distributing this naloxone through settings outside of the general medical system, as these settings were sometimes perceived as being stigmatizing. This study had several limitations. Our findings only represent the experiences and perspectives of individuals within New Hampshire. Additionally, because this sample was comprised of volunteers, those who participated may have had different perspectives than those individuals who chose not to participate. We were also unable to validate self-reported data either on participant demographics or on participants' experiences. This research was designed to better understand the experiences and perspectives of people who use opioids and of emergency personnel to better inform policy-level responses to the opioid crisis in New Hampshire. Our results suggest that illicitly manufactured fentanyl is a primary driver of the opioid crisis in New Hampshire, and both of our stakeholder groups identified fentanyl as being extremely available in New Hampshire and being inconsistently mixed into batches of drugs. Because of fentanyl's pharmacokinetics, people who use opioids were at high risk for using what may previously have been a safe dose and overdosing because of the added fentanyl. During an overdose, stakeholders described people who use opioids experiences interfacing with professionals. Emergency personnel identified this window of opportunity to sort of link patients with care and offer resources. And they felt frustrated by systems level barriers to referral post-overdose. Though this sample of people who use opioids were largely interested in being connected with treatment, emergency personnel sometimes felt frustrated by people who use opioids' unwillingness to engage in treatment referral post-overdose. The experiences with naloxone described by participants in our sample and in other studies emphasize the importance of treating withdrawal symptoms post-naloxone administration. Emergency settings, as described by Dr. Lofwall in the last presentation, are increasingly considering this issue by offering patients treatment with buprenorphine or with other medications to attenuate these withdrawal symptoms after an overdose, and this may be critical to encourage linkage with care. Another important implication of this study is the expansion of tailored services for the emergency personnel who respond. Despite providing detailed descriptions of the burden caused by responding to a massively increased number of overdoses, few emergency personnel had engaged with resources. Addressing this tool may mitigate harms and allow emergency personnel to more effectively respond. Finally, our study results provide strong support for policies expanding access to effective treatment for opioid use disorder, including medication for opioid use disorder, in addition to expanding access to harm reduction services like syringe service programs and naloxone. Since completing these interviews, New Hampshire has implemented several new programs and policies to improve access to treatment and provide more access to harm reduction services. These include the launch of the Doorway program in 2019, which allow people who use substances to go to a number of locations statewide that are sort of open anywhere, anytime, and will link patients to treatment immediately. In addition, New Hampshire has now opened more than 5 syringe services programs and have bolstered naloxone distribution efforts. Research should continue to explore the experiences with overdose and opioid use among people who use opioids in New Hampshire to examine how the implementation of these programs have impacted people's lives and people's experiences with using opioids. Before I stop, I just want to acknowledge the National Institute on Drug Abuse for supporting this work. And I want to thank all of our study participants, our community partners who assisted with the study, and the Dartmouth College research team. Thank you.
Thank you so much for that presentation. It was really intriguing, Elizabeth. And yeah, you know, I couldn't help but think about the two epidemics. You know, so we have the opioid epidemic, it's ongoing, and now we have COVID. And with COVID, we're so hopeful if only we had a medication. So I know we want a vaccine, but I think, you know, you often hear how we just don't really have effective medications. And then here with the opioid epidemic, at times, like the emergency personnel were sharing, you have someone who sorely wants treatment. The personnel with them, the person who just brought them out of an overdose wants them to have treatment, and yet we can't provide it. We have, right in the pharmacies where they're being turned away, we have the medication that they want. Diversion with the, you know, the formulations of buprenorphine we have now is not such a risky ordeal, yet they walk away unmedicated. I just can't get my head around that too well. but I think your presentation really brought home, you know, gaps in treatment and what more we need. So anyhow, we have plenty of time for questions. I invite some of the questions I'm going to read. Some of them are directed clearly to one presenter or another, but part of the reason to wait and hold them to the end and have the panel is we can get views from other presenters as well. So I'll kick it off with one that it's from Jin Yoon, and it's primarily about CM. Common criticisms of CM are that it's complicated and that the effects don't last following termination of treatment. While the latter in particular is likely an unfair comparison, what do you think the future of CM holds in light of some recent technological developments such as remote-based CM platforms, for example, dynamic care? So please, I think this is probably directed to Tia, but please feel free to respond across the panel. Tia?
Sure. Well, thank you, Jen, for that question. I think it's a really good question, and I'm really hopeful that technology-based solutions will help us close the dissemination gap. I think it's going to help both with getting CM out there and as well solving that problem of long-term implementation. As long as we can get the resources to people so that they can use the technology effectively, I think that's another thing. With the COVID happening and showing us how much we take for granted, I think access to reliable internet, access to good technology, I think on the one hand, it's really hopeful that dynamic care exists. I know that, you know, BCBH takes advantage of dynamic care, but as long as people have the access to the technology to make it work, and the people who are implementing the CM also have to be trained in effectively using it as well. We can't take that for granted, you know, just deploying it and not really carefully thinking about the incentives could be potentially a problem. But I am optimistic about it, and I think telehealth is something that we are increasingly considering as important as evident by the epidemic. So, but yeah, I am hopeful. I'm hopeful.
Yeah, I'll just jump in. I'm hopeful as well. One of the things that organizations like Dynamic Care can provide is some reassurance to Medicaid against their concerns about fraud. So rather than having, you know, multiple clinics throughout a community, each having their own incentive account, if you will, it could be the Medicaid funds, if they were willing to allow us to use them for this type of treatment, could be used through Dynamic Care, and that's who would be audited. So I think there's a lot of reason to be encouraged. Anyone else want to comment on that particular question?
I kind of have a comment that is related to it. I think that there was some work that, Steve, you may know who it was, or one of the other panelists or the audience, that was trying to get CMS to realize that contingency management is really real and that we shouldn't consider it like incentives, fraud, or kickbacks.
Yeah.
What's the
There's a
status on
major,
that?
it's an important point, Michelle, and that's kind of what was on my mind. So there's a major effort. Rick Rawson from our center is one of the leaders in the effort, and it's gotten to high levels. John Roll from Washington State University has Senator Murray involved in it, and so there are high-level discussions, but there's still some pushback from CMS. And one of the things I noticed just talking with our Vermont Medicaid folks is that the medical director is on board, but then it goes to lawyers who are totally, as far as I could tell, unfamiliar with drug abuse or CM, but they get very concerned about the potential for fraud. But I think, Michelle, as a physician, you would know much better than me, but I think there's always potential for fraud with Medicaid. And
Yes.
it's not
all the wheelchairs and everything, all that medical equipment, that's all like always.
Yeah, always. So, but I do
there's always, like, the incentives can be so small. So
like a established company and hopefully more than one, like Dynamic Care, who take on the responsibility of handling the incentives. And I think it'd be helpful, as I think what Jen had in mind with this question, in that the community clinicians don't necessarily have to be trained in CM. It can be implemented through Dynamic Care. But the point that I'm speaking to is that if CMS is concerned about fraud, then they can audit this established organization, and hopefully they would have all the accounting necessary to show that's being well handled. So I think it's really an important advance and kind of a new one. So we have to see how it plays out. So here's one for you, Michele. How easy is it from the patient's perspective to switch between long and short-acting buprenorphine options, assuming the long-acting product in question offers a comparable dose to their short-acting prescription?
So it depends which long-acting formulation they're trying to switch to, right? Because the concentrations really hugely vary, right? Like I showed you, Probuphine, which has less than 1 nanogram per ml, right, is equivalent to 8 milligrams or less. So I've got a lot of stable patients, but they're on 16 milligrams a day, and they would love to be on Probuphine, but it would be like going down by more than half their dose, and they just can't, they struggle to go on a dose that's lower to get them there. So for them, they're kind of stuck. I would love to see, another long-acting, more than a month, 6 months, 3 months, something for them. But we don't have it yet. For patients who are, on 8 to 24, the Brixadi has a whole bunch of different dose equivalents. Remember that table that I showed has the dose equivalents in weekly and monthly, and that's a pretty smooth transition. And going from weekly to monthly has also been demonstrated to be smooth. There is a published open label study in addiction. I think the first author is Frost on that. And then for subblockade, it's a little bit of a higher dose, right? But I've had a lot of success with patients with it. I think for some that have been on sublingual for a long time, they're very nervous about the switch and not having like their sublingual medication anymore. They're used to having it, and is it really going to work? So there's this mental component to it where they're really adjusting, but I've had lots of really positive feedback about it, like, how they feel like it's another step forward in their recovery. For people who have, established abstinence on sublingual and been in treatment for a little while. And then we have a lot of new patients coming in who are very, very unstable, lots of methamphetamine use, other, illicit use. And we're just worried we're not going to see them again, that they're not going to come back. Their dropout rate is so high. And so we just love to be able to get a long-acting injectable into them to prevent them from having an overdose death due to opioids. They're highly opioid tolerant coming into treatment. And so, we we sometimes get frustrated because then they're not coming for their weekly appointments because they have their medication on board for a month already. But, you know, they're really unstable, and we know the medications save lives, you know, like there's no doubt that buprenorphine and methadone in particular save lives. And that's through the pharmacologic mechanism of, you know, the cross tolerance and the opioid blockade. And so, you know, it's a balancing act a little bit, you know, trying to just make treatment as positive and as less punishing as possible. There's so many clinics that are really, I don't want to place blame, but they're not always positive experiences. There's a lot of, you know, administrative discharges, you know, and sometimes, you know, it's for infractions, and the infractions are polysubstance use. And it's like, well, in what world was buprenorphine or methadone or naltrexone approved to treat methamphetamine? You know, so like you're getting discharged for continued methamphetamine use, but you're doing better on with regards to your opiate use, but the providers are worried about liability. They're worried the patients still aren't really coming in. They're kind of intoxicated in counseling, so they're not looking like they're really benefiting from that. And there's all these really important, you know, questions for researchers, and that the clinicians are really struggling with. And they struggle with them for real reasons. And sometimes it's payers that put pushback on them to be like, well, they're still using. Why are they still in treatment? Your treatment's failing. So there's like this pressure to kind of get them to a higher level. But if a patient needs to accept a higher level of care, and a lot of patients won't want to go to a higher level of care. So then you're put in some really interesting clinical situations. So I really like the injectables because it gets rid of the provider's fear that their patient is going to die because they're not adhering to their medication. If they come in and they get that dose, you know your patient is good, or it's the best thing that you can do for them, that they're blocked for that week or that month or however long it is. And we just try then and then it eliminates a lot of the staff's worries about diversion and misuse. So they can really focus, you know, not on like trying to do counts and what's the urine test level and is it really meaningfully less or is it a different ratio? You can just be like, look, what's going on with you? How can we help you? We're happy you're here. Do you want a thing of water? Do you need transportation help? Like, you know, really making the clinic there to serve the patient, have it be more patient-centered, I think is what the injectables are allowing us to have. I talk too much.
No, that's wonderful. I have a question directed to Elizabeth. So there are emerging efforts, I think, initiated by the first responders where some places where this is getting going, they visit the overdose survivor the following day to try and get treatment initiated and that sort of thing. Is that sort of thing going in New Hampshire? You guys seem to be out in front on a lot of these matters with overdose, so I was curious.
Yes, there's certainly a couple different programs in New Hampshire. There's one program, for example, in the Laconia area, where first responders, the police department actually, and some other first responders have initiated a program in the community where they do reach out after an overdose. There's actually a number of different programs in different parts of the state, and I think we really need to sort of look at the effectiveness of some of these programs, but it's been amazing to see all of these programs just kind of blossom from the community, and communities really engage in coming up with creative ways to try to reach out and connect people with treatment and care and reduce overdose rates.
Yeah. It's wonderful to see it coming from the bottom up, and I think qualitative studies like yours, I'll admit, I have never done a qualitative study, but the kind of work you shared today is very informative. And I think that bottom up effort by the first responders is clearly pointing to a gap that, you know, many of us in the field have ignored. And so I think your point that we should be researching it is a great one. Yeah. So another question, this one with more to Tia. about, did you find evidence of publication bias in studies of CM? I think
We're
that's
still doing our analyses, so yeah. Steve knows.
Analysis to be done, but I appreciate Jess's point. The one, when I was reading it, one thing that crossed my mind is the two analyses that you presented, where when it's the psychomotor stimulant alone, you have 90% and large effect sizes. And then when you keep the incentive exactly the same daily amount, and now you're asking for absence from 2 to 7 drugs, then you get 58% successful studies. And that's kind of suggesting to me that the investigators are reporting out what they're seeing, and you would expect the efficacy to fall as you ask for more without increasing the incentive value. So from a behavioral economic unit price analysis. So that gives me some suggestion, some confidence that the good data isn't because with the single psychomotor stimulant targeted, that result isn't because people are just allowing negative studies targeting the single psychomotor stimulant to sit by the wayside, in that when they're targeting polydrugs, they don't hesitate to report negative results. So, but it's an empirical question, and that will be part of the analysis, Jess. So another one for Michele, it's from Sarah Heil, and hi, Michele. In the CTN study with pregnant people who have opioid use disorder, do you anticipate any issues with dose adequacy given increases in metabolism over the course of pregnancy?
So possibly, Sarah. So I think, we sometimes have to increase the dose of buprenorphine later in pregnancy, but they can do that. So it's flexible dosing in the study in both arms. So hopefully we'll be okay. And one of the questions I'm interested in seeing is if this might be like somewhere where the weekly product, because that's what's being used during pregnancy, is going to really be more helpful, just because it doesn't have that daily peak and trough. And so it's just, is that going to be more helpful, and maybe we won't have to increase it as much of the dose? I don't know. I think it's going to be interesting.
Well, stay there, Michele. Another one. Do you happen to know whether the cost of Brixani, how do you pronounce that, Michele?
So it's Brixadi and then Buvidal. And one of it's called one thing in Europe and Australia and another thing in the US.
Okay. So will it be similar to you can tell I haven't been doing opiates, Sublocade. Some insurances, include Medicaid, require prior authorization because of the cost of Sublocade, and it is often denied. So I think you get the gist of the question.
Yeah, so it's really interesting. In Kentucky and in most states, I think there is a prior authorization. And during the pandemic in Kentucky, we were able, the state Medicaid got rid of prior and reauthorizations for Sublocade. And then they recently said that that's going to be standing even after that. There was I think they won't say this. I just know from the prior authorization requirements and reauthorization requirements that we had in our state for Medicaid for sublingual buprenorphine literally were sometimes 100 pages long that we would have to send back in, because they wanted copies of all of the urine drug tests. They wanted copies of progress notes. It was all very focused on, is there presence of buprenorphine in the urine? What's the prescription drug monitoring report look like? It was very, to me, it was very is the patient taking their medicine? And as the payer, am I paying for someone who takes their medicine, or am I paying for them to sell it to somebody else or give it to somebody else? That's how it really felt. And talking to colleagues from other states, it's definitely very clearly where the focus was. So this idea that you're on Sublocade, you don't get a prescription anymore for sublingual, I guess you could, but it's not meant to be that way. It's supposed to be that's your buprenorphine dose for the month, is super attractive. to payers, even though it's costly. So I don't know what the cost of the CAM 2038 is going to be. I would bet that they're going to try and be competitive, right? It wouldn't be in their interest to be more expensive. So maybe the weekly is going to be like a quarter less than the monthly. I don't know. But in Kentucky, no subblockade anymore. So prior auths, and that's Medicaid. So we're super excited about that, and we are using it more. It's great in the hospital prior to discharge. So like if you have an addiction consult service, you get them on sublingual, and then before they leave the hospital, if you're able to give them a dose of subblockade, it makes everybody feel so much more comfortable, because it's hard to get an appointment within a week or 2 weeks of leaving the hospital with an addiction provider. I mean, it's hard with your primary care provider, or anything in healthcare is very difficult. So,
yeah, I was thinking too. You mentioned, Michele, the studies where they're going to be looking at the long-acting preparations with criminal justice populations. I mean, same thing in terms of the person leaving and then, supposed to go and find their provider and whatnot. Why not send them out protected? I mean, to me, that's sort of no-brainer, but yeah.
Yes, exactly. Like that, those are like the real settings, like the criminal justice settings are, I think some of them where they show that, the forced loss of tolerance, and then sending them out, I think they've like a 10-fold increase in overdose.
Yeah, right. Yeah.
So, I mean, it's like huge potential to save lives. And again, like that's criminal justice is where they're completely focused on diversion and misuse, right? And it's a huge reason why they don't want to have it there. So if we can get some more medical providers, more waivered providers really, linked up with criminal justice, that would be such a huge benefit for patient and public health.
What is the situation in Kentucky on opioid substitution medications with people who, while incarcerated?
There's a growing willingness for naltrexone or Vivitrol because it's an antagonist and it's long acting. So there is a push and a recognition for medication for opiate use disorder treatment. There's, I think, only one county that I'm aware of that's in northern Kentucky, which is very close to Cincinnati, so much more urban area, part of the state, that does allow buprenorphine, but interestingly, it's a subblockade program. And it's all because of diversion. Yeah.
Okay, so a question, we have a couple more. So one directed more towards Tia. I wonder why, if it's established, this from Jessica Leahy, I wonder why, if it's established extrinsic motivators do not effectively promote long-term motivation, why does CM seem to provide benefit? Are these studies limited to short-term benefits, or are some of those studies of longer duration?
So I think I alluded to this a little bit towards the end of the talk, if I'm understanding the question correctly. CM has shown to be extremely effective when it's implemented. And it's not unique to CM that there may be problems when the intervention is discontinued. And Steve made a great point about discontinuing medication. You see problems with that as well. So the studies did vary in their duration. And I would just point to some of the studies showing long-term benefits by implementing the study, implementing CM in a long-term fashion. I'm not sure if that answers the question, but yeah, I just think it's not a unique problem. And depending on what you're targeting, you got to think about that as well.
Yeah. I would have to say, I would just be simply amazed in a population like those with opioid use disorder that we've learned, over years, and we're almost there, that maintenance treatment is the way to go. Like, don't even try withdrawal or detox or whatever. Or if you do, be very careful. And yet we think when they develop another addiction to a psychomotor stimulant, that we're going to go in and we're going to treat that for 12 weeks and withdraw the intervention and they'll be fine. I don't know. I mean, it's always an empirical question, but I don't know. I can't find the logic in that. So my guess is if we're going to deal with this second crisis in the twin epidemic that people are referring to, we're going to have a long-term intervention for the psychomotor stimulant as well. Whether it's a medication or a psychosocial treatment, it's not going to be a short-term intervention. Everything is fine. Take that from someone who spent 20 years trying to treat cocaine dependence. I know a lot about it. I mean, you can get long-term outcomes. We got it with CM paired with community reinforcement, where you were making lifestyle changes where naturalistic sources of reinforcement could sustain longer-term abstinence. And we were successful in a number of trials. But there has to be some programmatic intervention that has a long duration, or else you will get relapse.
Yeah, I'm glad you brought up the CRA, Steve, because I think that's another really hopeful addition, and something that clinicians could think about as well, is really thinking about the external environment and restructuring that. I
mean, I was encouraging, but of course I admitted a few minutes ago that I'm not really active in, I'm indirectly active through Stacy and Sarah collaborating, but they're leading. So I'm hopeful that we've kind of surmounted the idea that we can treat opioid dependence or opioid use disorder with short-term detoxes. But I hesitate after making that declaration that those of you who are very active in the field would say, no, right in our hospital, people are still doing that. I don't know. I would like to hear from the experts. Have we surmounted the belief that you can treat opioid use disorder with a short-term medication intervention?
Oh, absolutely not. We haven't surmounted the belief that opiate use disorder is a disease. It's still believed to be, you know, like in your own control. I mean, this is why we still have the opiate epidemic and why we have life-saving medicines that are not routinely offered.
Yeah.
I mean, the way we're treating patients is like, would be the equivalent if I presented to the emergency room for like an acute stroke or an acute MI, and they said to me, Michele, what have you eaten lately? Have you had a bourbon, and have you had a Derby pie? And have you not been taking your aspirin to prevent stroke and heart attack? And if I say, yep, I'm sorry, I have been doing all those things. Well, Michele, here's the referral. We think you might be having an acute MI, and you can maybe go and get a stent over here that'll save your life, but we're not even gonna tell you that information. So we'll just make you feel like fault and tell you, you know, you need to work harder. Bye.
Yeah, yeah.
I mean, honestly, like that's where it is, and unfortunately, that's where it is in a lot of rural areas in America. I mean, we're working on the healing community study, and so we've spent a ton of time in like rural Appalachia, and some of the treatment venues, it's like going back to the 1970s.
Yeah, yeah.
Where, I mean, the medical directors are not gonna do it. Mm-mm.
I know.
I mean, it's so sad. So it's like there really needs to be a huge public health campaign. And that's really what part of the 4 states that are participating in the healing community study is there's this huge public health campaign, actual billboards with people's pictures on them saying like, I went into recovery with buprenorphine, and like little testimonials and stuff. And so interesting. I mean, and they're real people from the counties. And the comments that they get back, some are just heartbreaking, you know, like their sponsors are so upset with them that they admitted that they took medication. Family, you know, it was, so that pervasive stigma it kind of, to me, is like hand in hand. You were asking earlier, like, why is it like this? You know, we're talking about racial inequality and injustice and all this. And I don't know, I'm learning a lot about it myself. But like I kept thinking, like, why does this ring a bell? Like, and I'm not, you know, there's not a lot of diversity in Kentucky. So I'm like, why is this like so ringing a bell to me? And to me, it's the racial, you know, Black and white issues that we're talking about right now. It's behavioral health and everything else, medical and surgical, right? You have your insurance companies that you have your medical and surgical benefits, and then you've got your behavioral health benefits.
Yeah.
And
Yeah.
behavioral health has always been treated so poorly. You know, there was no parity, so we needed to have the Wellstone Parity Act, and that wasn't enough, so then we had to have the ACA. And that still wasn't enough because your governor had to decide if they were going to expand ACA. And it wasn't until like 6 months ago that in Kentucky, methadone is actually paid for by Medicaid, like methadone. So until like people get really pissed off and start like, I think, suing and the wrong people start dying, and then they get like a good attorney that can say, you're not offering like a standard of care, you never even educated the person about it, I think it'll continue.
Yeah, that's the one instance I know of that where now there's, for autism, there are these intensive behavioral interventions that are offered at a young age. And the way we got there is what you were just outlining. Autism isn't associated with lower socioeconomic status. So some affluent, educated parents who had autistic kids went in the literature and start reviewing studies where these intensive early interventions had wonderful effects, but they weren't offered, and they raised hell and threatened lawsuits, and all of a sudden now it's offered. And one of the problems is that disorders that we're dealing with are overrepresented in minority and economically disadvantaged populations, and we don't have those lawsuits that you're describing. But I agree with you. I think they may, everybody means well. I should say that's probably not true, but often this neglect is under conditions where people mean well. But one that still gets in my craw is cigarette smoking. And so we were recently working on trying to improve in our own hospital that any smoker who's hospitalized would not leave without a referral to the quit line unless they ask not to be referred. I mean, it's a condition where unless something changes, half of them are going to die from that particular problem, that nicotine dependence. And we're still working on it, but we failed in the first effort. We could not get sufficient traction. And it was, we were going to do it through the electronic health records, and we have other priorities in line and whatnot. But nevertheless, the way it ended up, we're still working on it. But right now, the status quo is smokers come in, they're in the hospital, and they leave without a programmatic referral. There's nothing programmatic on the books that's going to be done. And we know for almost 480,000 Americans every year are dying from that problem. The irony is that we were doing this, and we were shut down for a while because of COVID. So, I mean, as someone earlier said, we don't want to start pitting one disorder against another, but more people were going to die this year from smoking than from COVID. The hospital was all in on the COVID, but smoking, we can't make a referral to the quit line. It's too complicated. Maybe next year. So we have a lot of work to do. I have one specific question again for you, Michele. New York also does not require a PA anymore, and is a preferred formulation. I'm not exactly sure I know what that means, but do you?
Are you saying that it's the Sublocade is no longer
a PA anymore? What's a
prior authorization?
Oh, okay, and is a preferred formulation.
Are they talking about Jen? Are you talking about
That
Sublocade, or are you just talking about
Jen? Can you shoot us and flesh it out a little bit?
I'll be really excited if Jen is saying that New York also has no Sublocade prior authorizations and reauthorizations anymore. If that's the case, that will be lovely.
Jen, we're waiting on you.
A lot of states have moved towards having like fewer prior auths for the sublingual buprenorphine. So
Okay, speak to the prior authorization, Michele, if you could. I am not that familiar with it. So what is she referring to?
Oh, you are so lucky. You are not familiar with it. Oh my gosh. Think about
I retreated from some of this stuff into, yeah, anyhow, go ahead.
It is, it's like a huge paperwork burden for clinics to get patients the medication that their provider wants to prescribe for them. So, you know, some are really simple and easy that you have to fill out, but then the ones that we have in the addiction space, particularly with buprenorphine, have always been really burdensome. Lots of questions, lots of things like copies of things to attach, and then you have to fax it in, and then you have to wait to get a response, and then sometimes it just gets denied and it's really not clear why it's denied, and then you have to go and make a phone call for a doctor to doctor talk to get it reversed, and it ends up delaying care. And you know, sometimes when it's a reauthorization for a patient and you're really never giving patients much extra medicine, they end up running out in between, and if they can't afford it, then they're going through no medicine all of a sudden, so they go into acute withdrawal, and now they're at risk, and you're sitting here, you know, basically trying to argue with the payer just to let them fill the prescription. So that's what it is. Yeah. So you have to do those frequently before you start the medicine, and then periodically after you start it.
Right. Makes sense. Perfect sense. Okay. Any questions, any comments that we have not gotten to? Anybody on the panel have anything on their mind they wish they would have said? Here's your opportunity. Okay. Well, it was a terrific panel. I really appreciate your effort in preparing and coming and delivering wonderful presentations. The audience has been terrific. It's been, you know, somewhat a long 2 days. I think, you know, I couldn't be happier with how the program has gone overall. I think we addressed a wide swath of concerns around addiction and health in rural communities. We didn't come into it thinking we were going to have a Senator Leahy said at the start, you're going to wave a wand and we were going to have all the answers. But I think we have provided a lot of new information. I know I learned a lot. I hope everyone else who's been part of this, both presenters and audience, have learned some things as well. And we will be doing a special issue of preventive medicine as a follow-up to this conference. So presenters will be hearing from me in the near future. Some of you have been down this road before, and so you know it. But I really thank everybody. I thank the funding agencies that have made the center, the conference possible, our administrative staff, without whom we could never do this. And so I wish everybody, this time, normally I have to wish you safe travels, but one upside of the remote conference is that you're all in your safe homes, and but stay safe. And I really, again, I appreciate everybody's efforts in making this possible. So with that, I think we are officially adjourned. Bye-bye.
Thank you so much.
Yes, thank you very much.
Thank you.
Thank you.